The results of this study were interesting. Machine perfusion was found to greatly reduce the risk of delayed graft function, improve the rate of decrease of serum creatinine, and actually had an impact on 1-year graft survival, which again, I'm sorry, the only line that projects here is the machine perfusion group, but this does show a significantly improved survival from machine perfusion rather than cold storage. I think it's fair to say we have not embraced machine perfusion in our centre, certainly, but I think that it's something which we should be doing. Technically, it's a little bit more fiddly at the time of retrieval, but there's no doubt, and it's expensive to set up, but there's no doubt that this is something which we, to my mind, should be doing. I know that Professor Bradley discussed the laparoscopic donor nephrectomy yesterday during his talk. And obviously this is an attractive prospect for a potential donor, much more acceptable both cosmetically and with post-operative pain compared to the traditional flank approach. The majority of trials that have been undertaken had relatively small numbers in them and weren't randomised. But there is a meta-analysis that was published in 2008 of over 6,000 patients, and the open nephrectomy was found to have shorter operating and shorter warm ischemic times, but these did not have an impact, importantly or crucially, on delayed graft function. And overall, the laparoscopic group had a shorter hospital stay and faster return to work. And this is one study that was published in the BMJ in 2006, which was a randomised controlled trial of 100 living donors. No patients were converted from laparoscopic to open, and this compared, the laparoscopic with a mini incision, so not the traditional very painful flank incision, but more anterior mini incision. The laparoscopic group had a longer operative time compared with mini incision, longer warm ischemic time. You can see here that's 6 minutes versus 3 minutes, and again, statistically significant. But they also had reduced analgesia requirement, shorter hospital stay, better quality of life at 1 year. And I know that these results have been repeated or endorsed by Professor Mickelson's recent publication last week, which I don't have a copy of, Professor Bradley did yesterday. So I think the thing that interests me about the laparoscopic donor nephrectomy story is that I can't help but feel that the results of the trials are coming out once the practice has already been established and accepted as a good way of managing these patients. And my comment here would be that actually it's not only trials that change practice, it's patient choice, and there is no doubt that the donors have been very keen to hear about the laparoscopic approach to their nephrectomy, and that really has preceded the results of these good trials. The final study I want to briefly mention was published in 1995, and I want to mention it because I think that this is a study that did change practice, and this was a prospective randomised controlled trial of over 300 patients which compared different techniques of ureteric anastomosis and specifically the benefit of the use of prophylactic ureteric stents. So patients were randomly assigned to have a double J stent inserted at the time of transplant or not, and the insertion of a double J stent resulted in a significant reduction in ureteric complications post-transplant, and this is something which has now been adopted in common practice. So what I've tried to do, it's been a bit of a whirlwind, I'm afraid, to look at various aspects of transplantation, the immunosuppressive regimes, the antiviral therapy, and various surgical techniques. On undertaking this, you inevitably learn a few lessons. I think again, when we are establishing our trials, we have to really decide what are going to be meaningful endpoints, not necessarily short-term endpoints. We have to retain control of our clinical trials. Some of my concerns about these trials is they are driven by industry, where short-term outcome is what they want to see, whereas actually that doesn't inform practice in the long term. And as I said, particularly in relation to laparoscopic donor nephrectomy, other factors such as patient preference do influence, and correctly I would say influence, management decisions. Thank you very much.